Welcome to this video entitled Peptic ulcer disease. Let's begin with a definition. Peptic ulcer disease, abbreviated as PUD, refers to a group of ulcerative disorders of the upper gastrointestinal tract that require acid and pepsin for their formation. Ulcers differ from gastritis and erosions in that they extend deeper into the muscularis mucosa. The three common forms of peptic ulcers include Helicobacter pylori, abbreviated as HP, associated ulcers, nonsteroidal anti-inflammatory drug, abbreviated as NSAID, induced ulcers, and stress-related mucosal damage, also called stress ulcers. Next we will discuss the pathophysiology of peptic ulcer disease. 1. The pathogenesis of duodenal ulcers, abbreviated as DU, and gastric ulcers, abbreviated as GU, is multifactorial and most likely reflects a combination of pathophysiologic abnormalities and environmental and genetic factors. 2. Most peptic ulcers occur in the presence of acid and pepsin when Helicobacter pylori, non-steroidal anti-inflammatory drugs, or other factors disrupt normal mucosal defense and healing mechanisms. Acid is an independent factor that contributes to disruption of mucosal integrity. Increased acid secretion has been observed in patients with duodenal ulcers and may result from Helicobacter pylori infection. Patients with gastric ulcers usually have normal or reduced rates of acid secretion. 3. Alterations in mucosal defense induced by Helicobacter pylori or non-steroidal anti-inflammatory drugs are the most important cofactors in peptic ulcer formation. Mucosal defense and repair mechanisms include mucus and bicarbonate secretion, intrinsic epithelial cell defense, and mucosal blood flow. Maintenance of mucosal integrity and repair is mediated by endogenous prostaglandin production. 4. Helicobacter pylori infection causes gastritis in all infected individuals and is causally linked to peptic ulcer disease. However, only about 20% of infected persons develop symptomatic peptic ulcer disease. Most non-NSAID ulcers are infected with Helicobacter pylori, and Helicobacter pylori eradication markedly decreases ulcer recurrence. Helicobacter pylori may cause ulcers by direct mucosal damage, altering the immune or inflammatory response, and by hypergastronemia leading to increased acid secretion. 5. Non-selective non-steroidal anti-inflammatory drugs, including aspirin, cause gastric mucosal damage by two mechanisms. 1. A direct or topical irritation of the gastric epithelium. And 2. Systemic inhibition of the cyclooxygenase 1, abbreviated as COX-1, enzyme, which results in decreased synthesis of protective prostaglandins. 6. Use of corticosteroids alone does not increase the risk of ulcer or complications, but ulcer risk is doubled in corticosteroid users taking non-steroidal anti-inflammatory drugs concurrently. 7. Epidemiologic evidence links cigarette smoking to peptic ulcer disease, impaired ulcer healing, and ulcer-related gastrointestinal complications. The risk is proportional to the amount smoked per day. 8. Although clinical observation suggests that ulcer patients are adversely affected by stressful life events, controlled studies have failed to document a cause and effect relationship. 9. Coffee, tea, cola beverages, beer, milk, and spices may cause dyspepsia but do not increase peptic ulcer disease risk. Ethanol ingestion in high concentrations is associated with acute gastric mucosal damage and upper gastrointestinal bleeding but is not clearly the cause of ulcers. We will now look at the clinical presentation of peptic ulcer disease. 1. Abdominal pain is the most frequent symptom of peptic ulcer disease. The pain is often epigastric and described as burning, but can present as vague discomfort, abdominal fullness, or cramping. A typical nocturnal pain may awaken patients from sleep, especially between 12 a.m. and 3 a.m. 2. Pain from duodenal ulcers often occurs 1 to 3 hours after meals and is usually relieved by food, whereas food may precipitate or accentuate ulcer pain in gastric ulcers. Antacids provide rapid pain relief in most ulcer patients. 3. Heartburn, belching, and bloating often accompany the pain. Nausea, vomiting, and anorexia are more common in gastric ulcers than duodenal ulcers. 4. The severity of symptoms varies from patient to patient and may be seasonal, occurring more frequently in the spring or fall. 5. Pain does not always correlate with the presence of an ulcer. Asymptomatic patients may have an ulcer at endoscopy, and patients may have persistent symptoms even with endoscopically proven healed ulcers. Many patients, especially older adults, with non-steroidal anti-inflammatory drug-induced, ulcer-related complications have no prior abdominal symptoms. 6. Complications of ulcers caused by Helicobacter pylori and non-steroidal anti-inflammatory drugs include upper gastrointestinal bleeding, perforation into the peritoneal cavity, penetration into an adjacent structure, e.g., pancreas, biliary tract, or liver, and gastric outlet obstruction. Bleeding may be occult or present as melena or hematemesis. Perforation is associated with sudden, sharp, severe pain, beginning first in the epigastrium but quickly spreading over the entire abdomen. Symptoms of gastric outlet obstruction typically occur over several months and include early satiety, bloating, anorexia, nausea, vomiting, and weight loss. We will now look at the diagnosis of peptic ulcer disease. 1. The physical examination may reveal epigastric tenderness between the umbilicus and the xiphoid process that less commonly radiates to the back. 2. Routine laboratory tests are not helpful in establishing a diagnosis of uncomplicated peptic ulcer disease. The hematocrit, hemoglobin, and stool hemoccult tests are used to detect bleeding. 3. The diagnosis of Helicobacter pylori infection can be made using endoscopic or non-endoscopic tests. The tests that require upper endoscopy are invasive, more expensive, uncomfortable, and usually require a mucosal biopsy for histology, culture, or detection of urine activity. The non-endoscopic tests include serologic antibody detection tests, the urea breath test, abbreviated as UBT, and the stool antigen test. Serologic tests detect circulating immunoglobulin G directed against Helicobacter pylori but are of limited value in evaluating post-treatment eradication. The urea breath test is based on urine production by Helicobacter pylori. 4. Testing for Helicobacter pylori is only recommended if eradication therapy is considered. If endoscopy is not planned, serologic antibody testing is reasonable to determine Helicobacter pylori status. The urea breath test is the preferred non-endoscopic method to verify Helicobacter pylori eradication after treatment. 5. The diagnosis of peptic ulcer disease depends on visualizing the ulcer crater either by upper gastrointestinal radiography or endoscopy. Radiography may be the preferred initial diagnostic procedure in patients with suspected uncomplicated peptic ulcer disease. Upper endoscopy should be performed if complications are thought to exist or if an accurate diagnosis is warranted. If a gastric ulcer is found on radiography, malignancy should be excluded by direct endoscopic visualization and histology. We will now look at the desired outcome. The goals of treatment are relieving ulcer pain, healing the ulcer, preventing ulcer recurrence, and reducing ulcer-related complications. In Helicobacter pylori positive patients with an active ulcer, a previously documented ulcer, or a history of an ulcer-related complication, the goals are to eradicate the organism, heal the ulcer, and cure the disease with a cost-effective drug regimen. We will now look at the treatment of peptic ulcer disease. Let's begin with non-pharmacologic treatment. 1. Patients with peptic ulcer disease should eliminate or reduce psychological stress, cigarette smoking, and the use of non-selective non-steroidal anti-inflammatory drugs, including aspirin. If possible, alternative agents such as acetaminophen, a non-acetylated salicylate, e.g., salsartate, or a COX-2 selective inhibitor should be used for pain relief. 2. Although there is no need for a special diet, patients should avoid foods and beverages that cause dyspepsia or exacerbate ulcer symptoms, e.g., spicy foods, caffeine, or alcohol. We will now discuss pharmacologic treatment. 1. An algorithm for the evaluation and management of a patient with dyspeptic or ulcer-like symptoms is presented in Figure 29.1. 2. Eradication of Helicobacter pylori is recommended for Helicobacter pylori infected patients with gastric ulcers, duodenal ulcers, ulcer-related complications, and in some other situations. Treatment should be effective, well tolerated, easy to comply with, and cost-effective, as shown in Table 29.1. 3. First-line eradication therapy is a proton pump inhibitor, abbreviated as PPI, based, 3-drug regimen containing 2 antibiotics, usually clarithromycin and amoxicillin, reserving metronidazole for backup therapy, e.g., clarithromycin-metronidazole in penicillin-allergic patients. The proton pump inhibitor should be taken 30 to 60 minutes before a meal along with the 2 antibiotics. Although an initial 7-day course provides minimally acceptable eradication rates, longer treatment periods, lasting 10 to 14 days, are associated with higher eradication rates and less antimicrobial resistance. 4. First-line treatment with quadruple therapy using a proton pump inhibitor, with bismuth, metronidazole, and tetracycline, achieves similar eradication rates as proton pump inhibitor-based triple therapy and permits a shorter treatment duration, lasting 7 days. However, this regimen is often recommended as second-line treatment when a clarithromycin-amoxicillin regimen is used initially. All medications except the proton pump inhibitor should be taken with meals and at bedtime. 5. If the initial treatment fails to eradicate Helicobacter pylori, second-line empiric treatment should 1. Use antibiotics that were not included in the initial regimen. 2. Include antibiotics that do not have resistance problems. 3. Use a drug that has a topical effect, e.g., bismuth. And 4. Be extended to 14 days. Thus, if a proton pump inhibitor amoxicillin clarithromycin regimen fails, therapy should be instituted with a proton pump inhibitor, bismuth subsalicylate, metronidazole, and tetracycline for 14 days. 6. Treatment with a conventional anti-ulcer drug, e.g., proton pump inhibitor, histamine 2 receptor antagonist, abbreviated as H2 or RA, or sucralfate alone is an alternative to Helicobacter pylori eradication, but is discouraged because of the high rate of ulcer recurrence and ulcer-related complications. Dual therapy, e.g., histamine 2 receptor antagonist plus sucralfate, histamine 2 receptor antagonist plus proton pump inhibitor, is not recommended because it increases cost without enhancing efficacy. 7. Maintenance therapy with a proton pump inhibitor or histamine 2 receptor antagonist, as shown in Table 29.2, is recommended for high-risk patients with ulcer complications, patients who fail Helicobacter pylori eradication, and those with Helicobacter pylori negative ulcers. 8. For treatment of non-steroidal anti-inflammatory drug-induced ulcers, non-selective non-steroidal anti-inflammatory drugs should be discontinued, when possible, if an active ulcer is confirmed. Most uncomplicated non-steroidal anti-inflammatory drug-induced ulcers heal with standard regimens of an histamine 2 receptor antagonist, proton pump inhibitor, or sucralfate, see Table 29.2, if the non-steroidal anti-inflammatory drug is discontinued. If the non-steroidal anti-inflammatory drug must be continued, consideration should be given to reducing the non-steroidal anti-inflammatory drug dose or switching to acetaminophen, a non-acetylated salicylate, a partially selective COX-2 inhibitor, or a selective COX-2 inhibitor. Proton pump inhibitors are the drugs of choice when non-steroidal anti-inflammatory drugs must be continued because potent acid suppression is required to accelerate ulcer healing. If Helicobacter pylori is present, treatment should be initiated with an eradication regimen that contains a proton pump inhibitor. Patients at risk of developing serious ulcer-related complications while on non-steroidal anti-inflammatory drugs should receive prophylactic co-therapy with misoprostol or a proton pump inhibitor. 9. Patients with ulcers refractory to treatment should undergo upper endoscopy to confirm a non-healing ulcer, exclude malignancy, and assess Helicobacter pylori status. Helicobacter pylori positive patients should receive eradication therapy. In Helicobacter pylori negative patients, higher proton pump inhibitor doses, e.g., omeprazole 40 mg per day, heal the majority of ulcers. Continuous proton pump inhibitor treatment is often necessary to maintain healing. Pause the video and carefully scrutinize Figure 29.1, which is an algorithm for the evaluation and management of a patient who presents with dyspeptic or ulcer-like symptoms before advancing to the next slide. Pause the video and carefully scrutinize Table 29.1 summarizing drug regimens to eradicate Helicobacter pylori before advancing to the next slide. Pause the video and carefully scrutinize Table 29.2 summarizing oral drug regimens used to heal peptic ulcers or maintain ulcer healing before advancing to the next slide. Finally, let's discuss evaluation of therapeutic outcomes. 1. Patients should be monitored for symptomatic relief of ulcer pain as well as potential adverse effects and drug interactions related to drug therapy. 2. Ulcer pain typically resolves in a few days when non-steroidal anti-inflammatory drugs are discontinued and within 7 days upon initiation of anti-ulcer therapy. Most patients with uncomplicated peptic ulcer disease will be symptom-free after treatment with any one of the recommended anti-ulcer regimens. 3. The persistence or recurrence of symptoms within 14 days after the end of treatment suggests failure of ulcer healing or Helicobacter pylori eradication, or an alternative diagnosis such as gastroesophageal reflux disease. 4. Most patients with uncomplicated Helicobacter pylori positive ulcers do not require confirmation of ulcer healing or Helicobacter pylori eradication. 5. High-risk patients on non-steroidal anti-inflammatory drugs should be closely monitored for signs and symptoms of bleeding, obstruction, penetration, and perforation. 6. Follow-up endoscopy is justified in patients with frequent symptomatic recurrence, refractory disease, complications, or suspected hypersecretory states. Thank you.